Hi, I'm so elated to meet you in the program of JIP Academic Diabetes. Let us move to the case study. 54 years old male patient presented with breathing difficulty was evaluated in detail. Breathing difficulty grade 2. So, breathing difficulty grade 2 means he is able to walk slower than the same age on the ground level. So, that is called breathing difficulty grade 2. Clinically, patient was found to have pallor. So, any patient who presents with the breathing difficulty, generally I used to say you can squeeze into three important causes. One, either it must be a cardiac origin, or it may be a pulmonary origin, or the patient may have severe anemia. So, how we will differentiate whether it is due to pulmonary origin or cardiac origin or it is due to pallor? Let us see. So, on clinical examination, patient was found to have pallor. Of course, as I told you earlier, anemia is one of the important causes for breathing difficulty. On examination, no pedal edema and JVP is not elevated. When somebody doesn't have pedal edema and elevated JVP, what you have to remember that the absence of JVP elevation and absence of pedal edema doesn't rule out LV failure. You should be mindful that there's two entities called, one is congestive cardiac failure where both LV and RV dysfunction will be there. When somebody develops pure LV failure, they won't have any JVP elevation and pedal edema. So, absence of pedal edema and absence of JVP elevation will never rule out LV failure. You should be wary about that. So, in this patient, no pedal edema and JVP not elevated, at least I could say you could rule out congestive cardiac failure. Probably there won't be any RV failure, any additional RV failure. Pulse rate is 108 per minute, that means there is tachycardia. There is some kind of sympathetic overstimulation is there. Let us see what will be the reason. Blood pressure is 130/80 and respiratory rate is 26 per minute and saturation is 98%. But I have witnessed many doctors who are so content with the saturation. Somebody can have saturation of 96% or 98% in the room air, but with respiratory rate of 26-28. What I am trying to insist that anybody can have good amount of saturation at the cost of increased respiratory rate. With the help of increased respiratory rate, they can sustain or they can maintain good amount of saturation in the room air. So, what is the most important is, it is not only the saturation, to maintain good amount of saturation, how much of effort he has put, that you have to watch it. So, that effort can be manifested as respiratory rate. If somebody has respiratory rate 25, 28, 26, that means the patient is working hard to maintain the saturation. That means the patient is in distress. Either they may have some cardiac problem or they may have some pulmonary problem, or I could say sepsis. Sepsis can produce tachypnea without any involvement of heart and lungs because of direct stimulation of respiratory center by these toxins released by especially the gram-negative organisms. So, the most important is respiratory rate is the most important sensitive parameter, that you can't forget about it. And on systemic examination, of course, cardiovascular system, S1, S2. Generally, if you suspect cardiac failure, you have to hear S3 sound meticulously. But what you have to remember that the hearing the S3 sound, I think that it must be art. Probably over a period of time only you can learn, but definitely you have to seek or you have to search for S3 sound if you suspect LV failure. And in respiratory system, patient has basal crepitation. Yes, you have some finding. One, on systemic examination, patient has pallor, and general examination, patient has pallor, and systemic examination, patient has basal crepitation. Sometimes when you have basal crepitations, so basal crepitation, you may have various reasons. One of the important differential diagnosis other than LV failure is interstitial lung disease, that you have to remember. So, interstitial lung disease, probably if they present with idiopathic, idiopathic origin, then probably they may have only pure end inspiratory velcro crackles. It's like fine crepitations. So, it will mimic like a LV failure. Then probably I think that the history may be helpful. So idiopathic pulmonary fibrosis, I mean ILD, commonly seen in age group more than 60 years. They will have some subacute onset, probably 2 to 3 months. They may present with pure dry cough, and when you auscultate, that velcro crackle, something like tearing down, the sounds of tearing some salt paper, we used to say, that kind of that you have to be mindful. Probably it may be a rare, but you have to keep it in differential diagnosis of this fine crepitations other than LV failure. So abdomen soft, but any patient who presents with breathing difficulty, probably the examination of abdomen reveals, we used to say pulsatile liver. Then otherwise, so what would be the possible differential diagnosis? One, probably we have found out there is a pallor, probably severe anemia might have precipitated LV dysfunction, or pallor may be an incidental finding, or it may be a pure LV failure. So how you are going to evaluate with further investigation? Let us see the investigation. Patient hemoglobin is 8.5 milligram, definitely, especially male, hemoglobin is very less. Definitely you have to explore what cause it would be. Then WBC is normal, platelet is normal. So whenever you look at hemoglobin, the another most important investigation is mean corpuscular volume. I have seen many times this mean corpuscular volume is absolutely ignored or overlooked. It's very, very important. What you have to remember that this MCV will throw many differential diagnoses when it comes to evaluation of hemoglobin. Normal mean corpuscular volume, this value is at least you should have 80. So what is mean corpuscular volume? Mean corpuscular volume is a RBC size. When somebody has low mean corpuscular volume, like in this patient 68.8, that means the cell size is small. So patient has small size RBC, or otherwise called microcytes. Okay. When somebody has anemia and microcytes, you have many differential diagnoses. It may be iron deficiency anemia, or sideroblastic anemia, or you may have sometimes anemia of chronic disease and thalassemia, or due to lead poisoning. But the most important is iron deficiency anemia. Iron deficiency anemia would be the most important cause. I could say almost 90% of the cases of this kind of microcytic anemia, when someone has MCV, low MCV with hemoglobin, think of microcytic anemia. The most important cause is iron deficiency anemia. So when you think of microcytic anemia, especially iron deficiency anemia, in the age group of 40s or 50s or 60s, you have to think of blood loss, especially from the gut rather than the nutritional deficiency. So it is very imperative that when somebody has anemia with low mean corpuscular volume, low MCV less than 80, then think of iron deficiency anemia as the first cause. And second one, when you have MCV less than 80, you can comfortably rule out B12 deficiency, I mean the causes of macrocytic anemia. I have seen many doctors who has prescribed serum iron, B12 and iron binding capacity and serum folic acid. Please, when somebody has MCV more than 95, that means macrocyte, at the time probably you can think of macrocytic anemia. So one of the cause for macrocytic anemia, probably B12 deficiency or folic deficiency, where you can recommend all kind of tests. But when someone has MCV less than 80, like this patient 65, that indicates microcytic anemia, then that means you are almost dealing with iron deficiency anemia, to some lesser extent, probably very rarely sideroblastic anemia, lead poisoning. But when someone has microcytic anemia, don't write down B12, serum B12 and folic acid, because it's all denotes that it is a causes of macrocytic anemia. So when someone has MCV below 80 femtoliter, you can comfortably rule out serum B12 deficiency and folic acid deficiency. So this patient almost, we are dealing with iron deficiency anemia, and the most important cause you have to rule out is any blood loss from the gut rather than a nutritional deficiency. To find out the blood loss from the gut, either from the history, patient should say that patient passes melena. Suppose patient denies that he doesn't pass any melena, at least patient should be ordered for stool alkali blood. You should not forget about that. So this anemia might have contributed to some form of breathing difficulty. And another important routine investigation revealed that there is a gross elevation of urea and creatinine. Normal urea is 40 and creatinine is 1.2. But you should not be content with simple blood urea and creatinine assay. Two other important investigations to be ordered when you have elevated urea and creatinine. What are the two other important investigations? One is eGFR, glomerular filtration rate, and second one is albumin creatinine ratio. So what is the importance of GFR, glomerular filtration rate? In many of the times, when somebody has elevated urea, it never denotes that you are dealing with simple kidney injury. When you have excess protein intake, so probably this protein intake may give some fluctuating results of blood urea. When you have severe dehydration, urea may be increased, okay, as an isolated. And when you have more and more corticosteroid intake, then it may produce or it may precipitate protein catabolism, resulting in isolated elevation of blood urea. So when you have so many fluctuating causes of blood urea elevation, they say that here the GFR really lends a helping hand. So whenever you have elevated blood urea creatinine, to assess kidney function precisely, order eGFR. So when somebody has eGFR more than 90, that indicates patient has normal kidney function. 60 to 90, then probably patient has mild renal dysfunction. Then below 60, then you have some grades. Then probably if I take a depth, then probably it may a lot of saturating point. So what investigation you are supposed to order other than urea creatinine elevation? One is eGFR, as I told you earlier, and second one is albumin creatinine ratio. See, importance of albumin creatinine ratio is, even in the presence of normal blood urea creatinine, this albumin creatinine ratio definitely points out the signs of early nephropathy. So probably you can't be very much convinced that normal urea creatinine always signals normal renal function. In the presence of normal blood urea creatinine, if somebody has elevated albumin creatinine ratio, that signifies that the patient is heading towards early nephropathy. This is much applicable in diabetes. In diabetes, along with blood urea creatinine, so each and every visit, order for albumin creatinine ratio. Normal albumin creatinine ratio is less than 30 milligram per gram. This patient has significant amount, 180 milligram per gram. They say that when somebody has elevated blood urea creatinine, it obviously, you could sense that it obviously reveals that patient has renal dysfunction. Then what is the purpose of doing albumin creatinine ratio additionally? So in the presence of normal blood urea creatinine, probably I think that it may be a wise thing to order albumin creatinine ratio to find out the early change in the renal dysfunction. But when somebody has gross elevated blood urea creatinine, what is the significance of albumin creatinine ratio? Here the most important point would be, when somebody has increased blood urea creatinine along with the elevated albumin creatinine ratio, that signals more morbidity and mortality of renal pathology. So that always signifies that the elevated albumin creatinine ratio in the presence of elevated blood urea creatinine, once again insists or emphasize that it always indicates little bit poor prognosis. And electrolytes reveals that serum sodium 134, since patient has elevated blood urea creatinine, that is simply drives hyperkalemia. Whenever patient has renal dysfunction, the most important parameter that is going to be elevated is serum potassium. You are all aware that the kidney is the one that is responsible for handling the potassium balance. But what you have to remember that most of the time kidney always tries to retain the sodium at the cost of potassium excretion. So always I used to say kidney always would love to hate potassium. But whenever kidney suffers damage, the most important mineral that enjoys is nothing but potassium. So whenever you have whenever you have renal dysfunction, your kidney tends to get accumulated in your plasma, resulting in hyperkalemia. That situation only has happened to this patient. So serum potassium is on the higher side. Then this patient has been detected to have as a new diabetic status because patient has HbA1c is 8.7%. That indicates, as I told you earlier, 1 HbA1c always that is equal to 30 milligram of sugar. That means 8.7, that is almost close to 9%. That means almost this patient maintains almost 270 milligram of sugar. So probably this patient has been detected to have newly detected diabetic status. So then patient has been subjected to echo. As I told you earlier, one of the important cause for breathing difficulty is cardiac origin. So we have to do echo. Echo revealed patient has decreased the ejection fraction. That simply signals that patient has LV failure. But what would be the cause for LV failure? LV failure, you have many causes. Probably you have coronary artery disease, even alcoholic cardiomyopathy, even ischemic cardiomyopathy, even sepsis can produce global dysfunction. Likewise, even anemia can produce, even thyrotoxicosis can produce cardiomyopathy. There is something called stress cardiomyopathy. Then how will you differentiate all these things? The most important point in coronary artery disease induced cardiomyopathy is there will be regional wall motion abnormality. So what do you mean by regional wall motion abnormality? So one area may be preserved, it is contracting well, then one area is not contracting well. That means, so coronary artery is supplied by, you have a left main coronary artery and the right coronary artery. So when one particular branches is affected, the territories that is supplied by the occluded arteries will show there will be abnormalities in the contraction. When the territories that is not affected by the patent vessel reveals normal contraction. So when you have patchy contraction, here there is some abnormality contraction, here there is good contraction, that indicates some kind of one particular vessel occlusion. If you take alcoholic cardiomyopathy, you will have the entire myocardium will be affected. If you have anemia, the entire myocardium will be affected. Sepsis, entire, that is called global hypokinesia. But when you have regional, one particular region will be affected, or other region will be retained or sustained or preserved, then that indicates there is some form of coronary artery disease. So some form of coronary artery occlusion is there. So this patient, so overall diagnosis, how to correlate. So this patient has been affected by coronary artery disease resulting in LV dysfunction leading to LV failure. So that results in pulmonary congestion, that is reflected as basal crepitations, that leading to breathing difficulty. So probably this anemia must be a incidental, that's a separate phenomenon that has to be evaluated separately. So this patient probably has LV failure induced breathing difficulty. So how will you manage this patient will be seen in the next session. Thank you.